Good afternoon, and thank you very much. I would like to offer my profound gratitude to Abdul Malek Bouzik and the organizing committee for giving me this opportunity to share my experience with you. Now, I worked in an institution that was public for 50 years, and we started with very primitive opportunities. When I was training for cardiovascular surgery, I used to do only closed mitral valvotomies. But subsequently, we graduated from there, and currently, the hospital is doing something like 3,500 cases a year, and there is everything from infant cardiac surgery, neonatal cardiac surgery, to cardiac transplantations. Everything is being done in that institute. In 1959, the congenital heart surgery program took off with two pioneers, Dr. Reeve Betts, who came from Boston, and Dr. Gopinath, who is the doyen of cardiovascular surgery and who taught a number of students and who spread the idea of developing heart centers in the country. ASD closure was done with surface hypothermia by Dr. Reeve Betts and Dr. Gopinath. And VSD closure was done in 1961, and we progressed from there. Generally, adult cardiac surgery was the only thing that was being done. We were doing with a disc oxygenator, and then we graduated to a bubble oxygenator. And as you can expect, the technology had not developed very well at that time, and India did not have the technology with it to develop the adult pediatric cardiac surgery. And so we started with this, just like every other institution in the world in that period of time. And the infrastructure was very poor. We first of all did not understand the need for an intensive care unit, even for the adult surgery, and developing that was first in our mind. And then, of course, the results were not very good. The results were quite poor. And then we progressed from there to a slightly higher level. We invited very eminent pediatric cardiac surgeons from around the world. Sir Brian Barrett Boyce from New Zealand, Tim Cartmill from Sydney, and Dr. Subramaniam from Buffalo. They all came to our institution. They taught us how to do the pediatric cardiac surgery procedures. They also trained our doctors. Some of my colleagues went to these centers and they learned how to do these surgeries because they were doing a very large number, and the numbers actually mattered in their being able to do hands-on training in those centers. And then they came to our institution and demonstrated these surgeries in our institution so that we learned immediately how to develop this program. The first step was to recognize that pediatric cardiac surgery is different from adult cardiac surgery. It is not a scale down of adult cardiac surgery. It is quite different. The physiology is different, the structure is different, the responses of the infants and children to cardiopulmonary bypass and to the techniques that we use in open heart surgery is totally different. So it is not the same as adult cardiac surgery. That recognition is the first thing required for developing a good pediatric surgery program. There was need for exposure and training. So our surgeons went abroad to good centers which were doing large volume pediatric cardiac surgeries, infant cardiac surgeries, like I mentioned, and they got trained for a year or two. And then we sent the anesthesiologists. Some of our nurses went to the different programs and they learned how to take care of these children post-operatively. And we also sent our perfusionists to learn new techniques in cardiopulmonary bypass. We had CME programs, continuing medical education programs, because our institution was a very large academic institution. We had workshops. We had visiting surgeons coming and teaching the younger generation of trainees in our hospital. We had professional groups like the Pediatric Cardiology Association, as well as the Pediatric Cardiac Surgery Association. And we started publishing our results generally in the beginning on adult, slightly older children, pediatric congenital heart surgery. Then there was, between 1980 and 1990, there was an emphasis on developing a dedicated pediatric cardiology opportunity. So our cardiologists, they were sent abroad, they learned how to do echocardiography, how to identify, how to diagnose, and in centers like Mass General Hospital or the pediatric unit in Washington, and they came back and they were capable of making the diagnosis quite accurately with just echocardiography. We had a cath lab which were doing mostly pediatric angiographies and also interventional pediatric procedures. Then the echocardiography graduated from transthoracic echocardiography to transesophageal echocardiography, and we transferred that into the operating room. Then we developed a pediatric intensive care unit. This was, I think, a very significant step in developing a pediatric cardiac surgery program. Without the intensive care unit and without the intensivist, whatever surgery you do, it may be the best, but postoperative care sometimes increases the mortality if you don't have specialists to look after these children. Between 1990 and 2000, we progressed to children under 10 kilograms and down to 5 kilograms. We developed the infant technology and started doing neonatal surgery. And also, there were two big centers. One was in Chennai, and one was in All India Institute in Delhi, which had developed a very good pediatric and infant cardiac surgery program in India. Subsequently, from 2000 to 2010, adding more pediatric cardiac surgery units became essential because our population is about 1.2 billion, and out of this, there are almost 6 to 8 million children with congenital heart disease. And most of the diagnosis is made many, many months or even years after birth. So this diagnosis of congenital heart disease at birth was not existent. But we started that program from our institution, and we used to go to the ladies in the maternity wards and explain to them the need for a fetal echocardiography and make diagnosis and advise them on how to deal with the problem. Neonatal and infant surgery units developed in other parts of the country, and we had a dedicated pediatric intensive care unit, which was separate from the adult pediatric unit, adult cardiac surgery intensive care unit. We had something like 36 beds for adult cardiac surgery, and we developed an infant cardiac surgery ICU for about 10 patients at the first opportunity, and then it has extended now to 20 patients. And then we got some very well-trained intensivists, dedicated intensivists for the pediatric ICU. These are the centers in the country. The biggest center and the first center to develop a pediatric cardiac program was in Delhi. And then the Chennai, Dr. Cherian was the first one who developed an infant cardiac surgery program in Chennai. There were many other centers that came up afterwards. And today we have something like 16 or 18 pediatric cardiac surgery units in the country. Almost all of them, except 3 or 4, are in the private sector. Only 3 are in the public sector. So those patients who are poor and who cannot afford surgery have to go to the public centers, whereas the rest can go to the private center if they can afford to pay. Also, I must say in India, we have 3 centers which are totally free. These are institutions started by philanthropists and dedicated to patients who are poor and who can come and get their operations done. Some of the institutions go to the extent of paying them their return train fare to go back to their homes, because these patients sometimes come from a long distance. So those are the opportunities for pediatric cardiac surgery in India. And subsequently, Transthoracic echocardiography was the mainstay in diagnosis. Intraoperative transesophageal echocardiography made cardiac surgeries much more successful because we could assess immediately on the table residual defects, uncorrected lesions, and problems pertaining to the ventricular function. And this effort of getting the equipment and having it in the operating room, having the opportunity to diagnose all this made a lot of difference in the mortality of these patients. And then pediatric cardiac interventions. So now the cardiologists started doing all the interventions. They used to do balloon atrial septostomy. They will use implants to close the atrial septal defect, the patent ductus arteriosus, or they use to keep the patent ductus open, and also to dilate the coarctation. So a lot of surgery which was not open heart surgery went to the cardiologists. They were doing many of these procedures which at one time we were doing as surgeons. And then of course the devices, septostomies and stents made a lot of difference for the patients also, and because they avoided surgery. And then we had much better and improved monitoring. So we had well-established pediatric cardiac surgery programs. We had cardiology and cardiac surgery training programs in which the students came and spent 2 to 3 years in learning all these diagnostic as well as therapeutic techniques, and they were certified. So now we had certified pediatric cardiac surgery and cardiology staff. It was not an adult cardiac surgeon or one who's got a postgraduate degree in cardiovascular surgery would go and do pediatric surgery. Now they have to have a pediatric surgery certification to do infant and newborns. Then our doctors travel a lot. They go to foreign countries, they go and attend conferences, and they present their papers. They are in touch with doctors and pediatric surgery programs abroad. And at one time, I think it was about 10 years ago, we introduced the extracorporeal membrane oxygenation technique. So this was very important because this was one equipment which was one opportunity to save some of the most difficult, complex congenital patients who had undergone surgery. So we also thought of, in being an academic institution, we also thought of one particular aspect. Now, many of you have gone abroad and trained yourself. When you come back, you find that the conditions in your country is not the same as, say, in America. So you cannot transfer that technology to yourself and try to do something that sometimes becomes a failure. On the other hand, you have to innovate and adjust to the needs of your population. That was one of the biggest problems for us, how to cut down costs, how to make this available for many patients from different parts of the country. And these deficiencies had to be overcome. We had to reduce cost. We had to improve operative and post-operative care. We had to contribute in the sense we have to develop techniques which others can use, which were not available in pediatric surgery until then, and add new equipment and new instruments to make it easier for us. This is the cost of cardiac surgery in India. As you can see, I think we cannot make it any more inexpensive to do cardiac surgery in India. Inside of $1,000, most of the surgeries for pediatric as well as adult cardiac surgery can be done almost in all institutions. The cost of surgery goes up in the private institutions by 2 or 3 times. We also opened a valve bank, which was very essential for cutting down the cost for using homografts. And so we used valve conduits, arterial and venous grafts. We used pericardial patches, which were preserved in the cryopreservation techniques. And of course, we used the valves to reconstruct the right ventricular outflow tract, to replace the aortic valve, and in some cases, even to replace the mitral valve. This is some of our publications. We have published on many aspects of pediatric cardiac surgery in India, and some of these articles have brought out the innovations that we have done. Now, this is an article which explains exactly all the steps that we have taken to reduce the cost of surgical correction of congenital heart disease. Then we got international recognition. Now, we attract students from Australia. We attract students who want to take up their sabbatical, even from United States. They come and spend a month because the enormous number of congenital heart disease patients you're going to see in 1 month, they would probably see in a year. So that opportunity is there. So these students now come and spend time in the All India Institute to learn both diagnosis and treatment options. Then we had peer-reviewed publications. We had international conference. And one of my students also got the Graham Traveling Fellowship, and he worked with Dr. Richard Jonas in Washington for a year. And we had national and international workshops, which are very interesting. I'm sure Professor Carpentier also remembers that he visited our institution and he performed surgery on the mitral valve. But of course, that was an adult program. And similarly, we have had surgeons from Australia, United States, and Europe who have come and operated in our hospitals. Then we had wet labs where we can train the students to see exactly the anatomy and the procedures in the lab. And catheter interventions became much more aggressive and much more active. And we opened a registry for pediatric cardiac surgery. Some of the innovations that we had in this particular area is that I first used the right atrial wall patch as a patch for closing atrial septal defects and ventricular septal defects. Now, the advantage of this was that it was autologous, it was living, it was free, and it did not cost anything to the patient, and it lives. And what we have seen in this experience is that this particular patch, the right atrial free wall patch, will survive inside the atrium and function. So it's a wonderful thing to think of options when you're doing and try to solve problems that you may face in a particular situation. So we have developed a new technique for transposition. We have also introduced a valve patch for VSD closure because many of these children come at a later age with pulmonary hypertension. And you cannot close the VSD completely. You have to leave it open for a while. So we developed a patch that had a valve, and over a period of time it closes by itself. Then I introduced the transaortic closure of tetralogy of Fallot. And this can be done in slightly older children who have a large aorta. And it's superb exposure of the right ventricular outflow tract as well as the VSD through the aorta. And we also introduced minimally invasive techniques. These are some of the publications that we had on these innovations. And we also had one of my colleagues developed the technique of extracorporeal extracardiac total cavopulmonary connection, avoiding cardiopulmonary bypass in patients with, say, tricuspid atresia or single ventricle pathology. And these are some of the publications that we had here. And this is one of the very important publications from our institutions where we innovated. One of my colleagues who is now in the private sector, he performed arterial switch operations after banding the pulmonary artery and preparing the left ventricle to take up the... So this experience started this particular technique around the world. And then we had hybrid techniques. We invited the cardiologist to the operating room and to overcome problems like residual shunts or small ASDs that are left over. They could automatically go and close, or they could help us to plug the patent ductus arteriosus after the surgery without having to go and dissect in that area. So we had extracorporeal, this thing, modified ultrafiltration, which also helped these patients to recover from the post-operative problems of water retention. Then correction without cardiopulmonary bypass, not just the closed surgeries like PDR coarctation, but many other procedures can be done without the use of cardiopulmonary bypass. We had better communication, both with ourselves, with the cardiologists, with the intensivists, with the anesthesiologists, as well as international surgeons and international staff who could help us in improving our results. And we had developed pediatric teams not just in our institution, but outside. Our team had gone outside, taught them the techniques, taught them the need for developing the intensive care unit, etc. And then, of course, the management of arrhythmias became much more aggressive, and the cardiologists would be able to do all this in their cath lab. And I am particularly experienced in rheumatic heart disease valve repair, and we published our results in rheumatic valve repair in children, which was well accepted around the world. And I would like to conclude by saying that it's a very painful path. If you are going to start a cardiac surgery program for congenital heart disease, don't be under the impression that you can transfer your technology from adult cardiac surgery and start one. It takes time to build a pediatric cardiac surgery program. You have to have perseverance, and you have to set international standards. You have to achieve that. Only then your center will be recognized around the world, and you will have better peer review. You have to find funding, resourcing for equipment, for staff, for getting the necessary infrastructure developed to do these programs. And of course, you can advance, and innovations, they are very important. Cost cutting is something that may be important in many other countries also, because in India, there's just the patients cannot afford cardiac surgery. So we have to find some way of making it affordable and making it easier for them to come and have their surgery done. Thank you very much.